Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to be talking about burden of disease and the topical pathway for mild to moderate atopic dermatitis. Our moderator this evening is Dr. Mark Kaufman, who is Chief Medical Officer at the Advanced Dermatology and Cosmetic Surgery, Clinical Professor of Dermatology at the Icahn School of Medicine at Mount Sinai, and Board of Directors of the American Society of Dermatologic Surgery and Board of Directors of the Florida Academy of Dermatology. Our speaker this evening is Dr. Douglas Kress, who is Chief of the Division of Pediatric Dermatology at UPMC Children's Hospital in Pittsburgh. We'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit the questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Remember, if you want to submit a question, use the question pane on the right-hand side of your screen, and I wrote a little note there so you can see exactly where you can write the question. So without further ado, I will pass the floor virtually to Dr. Kaufman.
Thank you, Roxanne. And I'd like to just tell you guys tonight that our webinar is part of the IDEF series. And if we can go to the next slide, thank you. The International Dermatology Education Foundation, Dr. Kircik is president, and it is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. And these are just examples of some of the sessions that we've had recently, where we've had key opinion leaders talking about various different disease states. And you can follow the IDEF on Instagram, LinkedIn, Facebook, or just go to the website, which you see below, idefeducationalseries.com. And with that, I'm going to turn the session over virtually to Dr. Douglas Kress from UPMC Children's Hospital of Pittsburgh. Doug, it's all yours.
Thank you, Mark. Thank you, Roxanne. And I appreciate everyone joining us tonight. We're going to talk about a little bit of an update on the atopic dermatitis. We just see if the slides are going to work here. Oh. Roxanne, I think I might need, there we go.
Nope.
So we are going to talk about mild to moderate atopic. Oh, I think we got them. Mild to moderate atopic dermatitis, burden of disease, and a topical pathway for JAK inhibition. We're going to cover this more than once. So briefly, I want to talk about the important safety information for all JAK inhibitors. When patients take the oral JAK inhibitors, there's an increased risk for serious infections, all-cause mortality, malignancies, specifically lymphoma, major adverse cardiac events, thrombosis, and stroke. But this is the topical JAK inhibitor, so we are going to talk about what really happens with this one a little bit later in the presentation. So first, we're going to talk a little bit about the prevalence of atopic dermatitis. This is one of the diseases in our subspecialty that's really been on the rise, and we see it in very young kids, and now there's some data that we see it more in adolescents and adults than we used to believe. We're going to talk about the clinical manifestations, but I'm going to kind of
Oh, we've lost Dr. Kress.
over those because I know everybody on this call knows what atopic dermatitis looks like. And then we're going to talk about how we manage atopic dermatitis. Sorry, we are having some technical difficulties here getting the slides to advance.
If you want me to advance them, Dr. Kress, just let me know.
Yeah. Roxanne, can you do it, please? Next slide.
No problem. I'm going to just go back because there's a couple of slides that were. Let me know when you want me to stop going back. Okay, I think you've gone through this one.
Yeah, so now the next one, there we go. So you can see the incidence. We see 9.6 million kids under 18, another 16.5 million adults, and most of those patients are mild to moderate, which is generally what we see in patients with papillosquamous disease. Next. So we know that itch is really the most burdensome thing that we see in atopic dermatitis, and historically we've always managed these with very complex regimens. I would give one steroid for the face, another one for the body, then a non-steroid anti-inflammatory maybe on the weekends to take a break. It's really nice to have the option to just treat with one thing that's safe to use anywhere. And now we have this treatment FDA approved down to the age of 2. Next slide, please. Next. Next slide, Rexon. All right, so this is the pathophysiology of atopic dermatitis. And we've really learned a lot about this over the years. We've always known that there was an inflammatory component and that the skin barrier was abnormal, but we've really learned recently that these things are linked. And we have treatments now for all these different cytokines that you see, IL-4 and IL-13. There's a drug out that inhibits thymic stromal lymphopoietin that's FDA approved to treat asthma. We have drugs out now for IL-31. And we know, though, that all of these important cytokines that are elevated in the skin of patients with atopic dermatitis are mediated through JAK1. So that's how JAK1 inhibition can treat all the things that are wrong with atopic dermatitis and do so very quickly. We are going to talk about that as well this evening. Next slide, please. So when we look at IL-4, IL-13, IL-31, we can see that several of those cytokines play a role in triggering pruritus. They also stimulate the differentiation of Th0 cells into Th2 cells, and then that leads to production of more IL-13, and then we get the IL-31 and TSLP. What we've learned recently is that IL-4 makes the sensory nerves more susceptible to the effect of IL-31 and TSLP. Just for completeness, for those of you that haven't used JAK inhibitors a lot, we know that the JAK inhibitors bind to these receptor complexes that go through the membrane. And then once they're inside the cell, there's an interaction between the JAK pairs and STAT pairs, and then the STATs take information of the nucleus. And again, we mentioned that IL-4, IL-13, IL-31, TSLP, all the things that affect itch, barrier, and all those things are JAK1 mediated. And we know that Opzelura, or ruxolitinib, is a JAK1/2 inhibitor. Next slide, please. So now we're going to look at the efficacy and safety profile of Opzelura. Next slide, please. So in the initial studies, TRuE-AD1, 2, and TRuE-AD3, they basically had 2 different strengths of Opzelura compared to vehicle, and they did that for 8 weeks. The drug is used once a day. Or sorry. Oh, hello? Oh, yeah. You can see that the inclusion criteria is they had at least 2 to be over the age of 12. They had to have atopic dermatitis for years. They needed to have an IgA score or moderate, and their body surface area, excluding the scalp, had to be 3 to 20%. Next slide, please. Next slide, please. So demographics, as you can see, again, patients were over 12, and you can see the distribution there between 7 to 11, and then over 12. You can see here consistent skin clearance across all ages with Opzelura. Patients had to get a 2-point improvement, but then to be clear or almost clear. So if someone went from mild to almost clear, that doesn't count, right? You had to go from mild to clear or moderate to almost clear. And you can see that in the adolescents and adults, in TRuE-AD1 and 2, we got about 27, 25% compared to very low placebo rates, got that clear or almost clear. It's better in the pediatric trial, 2 to 11, 35%, and we expect to see that, and we've seen that in other young pediatric trials because the skin is thinner, we get more rapid response to all of these medications. Plus, these kids have been exposed to less treatment over the years than the adolescents and adults. When we look at patients who achieved that IgA clear or almost clear, at the primary endpoint at week 8, you can see it was 53, 51%. in adolescents, and then 56% in the 2 to 11. So still a little bit better. Next slide, please. So here are some pictures, baseline week 2 and then week 8, and you can see that there's really noticeable improvement as early as week 2, and then really significant improvement by week 8. This was someone who was a baseline IGA of 3, moderate. By week 2, they were mild, and then by week 8, almost clear. Next slide. Here we see one of the young children by the diaper. You can see it's a 2-year-old at baseline, pretty classic flexural atopic dermatitis, age 3, and then really significant improvement by age 2, and then by week 2, and then clear, completely clear by week 8. So that is really for a non-steroid anti-inflammatory and fast. A significant improvement. Next slide, please.
So Dr. Kress, I think I'm going to close your camera because sometimes you're cutting
Next
in
slide,
and out.
please, Rexha.
Can you hear me, Dr. Kress? Oh.
Okay.
So because
Yeah, I can. Can you hear me?
Yeah, we can hear you, but
Yeah,
I'm going to cut your camera.
I'll close the camera.
Okay, I just closed it. There you go.
Great. Is that better?
Yep.
Okay. All right. So here, is that better?
Yes, it is.
Okay. So here we see a 60. Okay, terrific. Well done. So here we see a 69-year-old male with lesions on the dorsal hand, baseline, and week 5, and then a 20-year-old female, again, also baseline, and you can see several weeks in. So really significant improvement in all of these patients. Next slide. EASI-75 is obviously another way that we can look at these, and you can see the improvement significantly compared to placebo for True 81, True 82, and then as we discussed the pediatric trial, better still, 67% of patients got to that EASI-75 at 8 weeks, and then EASI-90, which is really, you know, the best response we see in clinical trials. 44% of patients got to that EASI-90, which is really, you know, one of the best numbers we've seen in topical treatment for atopic dermatitis. Next slide, please. So we see here skin clearance in patients with higher disease severity. And again, you can see the Opsilor numbers in the 50s and 60% at week 8, and then EASI-75 into the 75%. So really significant numbers here. Next slide, please. So again, before and after treatment, here we see a baseline moderate, and then 2 weeks in, mild to almost clear, and then clear at week 8 in a 5-year-old. Next slide. And here we see you can use this in skin of color patients as well. So you can see on the baseline, and then the week 6 picture, you can see significant improvement in the post-inflammatory hypopigmentation, that kind of pityriasis alba look. And this is a 33-year-old African-American female who originally had a body surface area of 14%. So that's a really nice response. Next slide, please. So itch also we know is very significant with JAK inhibitors. What you need for the FDA is what's referred to as the itch NRS of 4. So you need a 4-point improvement. But one of the things that JAK inhibitors can get you is an itch 0 or 1. So obviously patients that you get a 4-point improvement in their itch scale are really happy that their itch is better. But patients that get to itch NRS 0 or 1 really have the itch now not have any impact at all on their quality of life. And you can see that in a post hoc analysis, patients on Opsilora get to that itch 0 1, you know, as early as 1 day. You can see 19% at 2 days, and you know, almost a third of patients get there by a week. So that's really something we've not seen before in dermatology, NRS 0 1 that rapidly. Next slide, please. So this is a trial that looked at how rapidly we see the itch. And you can actually see in this clinical trial that a significant percentage of patients had improvement in their itch as early as 15 minutes. And you can see that it continues to get better and better. And I've actually checked this out in my office. You know, we have samples. I think many of you guys have samples as well. And you can give patients samples and see how quickly it works for their itch. My wife had a situation where it worked as quickly as 5 minutes for her, but this is published data at 15 minutes. So, you know, if you're going to put somebody on Opzelura, you can let them know it's going to work very quickly for the itch. It can work quickly as well for the rash, and it can work to a significant extent for both the itch and the rash, just as monotherapy. Next slide, please. So here we see again real world treatment baseline, and at week 8, significant improvement in an 88-year-old, both with the itch and the rash. Next slide, please. So this is now the long-term extension out 52 weeks, both true AD1 and 2, and then true AD3. And you can see patients, you know, 74, 75% of patients maintaining that level of improvement through a year. So this is a drug that can be used safe in the long term. You use it when it's there, not when it's not. And you can see that 70% of patients had either clear or almost clear at some point during that 52-week clinical trial, the 44-week extension. Next slide, please. So among those on Opzelura since day 1, patients over 12 had a median of about 4.5 months off treatment over the course of the year. And the pediatric trial was a little bit better, about 5 months off treatment. So bottom line, you know, after you use it for those 8 weeks, you're basically going to use it about half the days. Again, use it when it's there, not when it's not. We don't see rebound like we see with some steroids. And again, it certainly seems to be safe to use long-term intermittent therapy. So that's kind of what this data shows. Next slide, please. So mean total affected body surface area, not surprisingly, as you use the drug on the areas of eczema, they go away. And then as you use it as needed through the 52 weeks, you're going to need to use it on less and less of the body surface area. And if you look at the vehicle control that crosses over at 8 weeks to the active, you can see how rapidly those patients catch up, and then those lines are basically the same at 52 weeks. So really a nice series of trials. Next slide, please. All right, as far as side effects, again, in the 8 weeks, this is Opzelura versus vehicle. There's a little bit of nasopharyngitis, you know, very low numbers on bronchitis, ear infection, eosinophil count, really not much there. And this is similar when you stretch out through 52 weeks. So I have not found any side effects in my patients. Next slide, please. Please, Roxanne. All right, so these are, oh, let's go back one. Oh, you can just stay here. So yeah, there we go. So this was specifically in the kids age 2 to 11. You can see URI not a difference between Opzelura and vehicle. The trial was done during COVID-19, so you can see not much of a difference there either. And then through 52 weeks in the pediatric population, you know, those numbers are what you expect in patients with atopic dermatitis and URIs, nasopharyngitis. And again, you know, this was done during the height of COVID, so some small COVID numbers there, but no concerning outcomes. Next slide, please. So very briefly, for those of you that may not have had an opportunity to play with a lot of JAK inhibitors, the black box warning comes from something called the oral surveillance trial, which is a trial that looked at Xeljanz or tofacitinib along with methotrexate in the United States for patients with rheumatoid arthritis who are greater than 50 and have more than one cardiac risk factor. That trial was compared to adalimumab plus methotrexate in the United States and etanercept plus methotrexate in Europe. And in that trial, in that patient population, the oral JAK inhibitors were associated with an increased risk of all the things that we talked about. Infections, malignancies, major cardiac event, blood clot, and stroke. That has not been seen in the topical JAK inhibitor trials, but all the JAKs with one exception carry the black box warnings. Next slide, please. So again, here's the long-term TAEs in 52 weeks. The way I like to describe these slides is a lot of zeros, right? Small number of infections. If you look, the highest number for malignancies is in the vehicle group, right? So it really just looks very, very safe. And we do have data that I don't think is part of the deck that after the first day, Opzelura is not really absorbed because it works so quickly to repair the barrier and get the eczema better that absorption doesn't really occur in a significant way after the first day of application. Next slide, please. So this was a randomized double-blind dose-ranging vehicle control trial. They looked at several different strengths of the Opzelura. This is how we ended up with the current strength of the cream that we have. Next slide, please. And you can see that this is a mean percentage improvement in the easy score compared to triamcinolone. So every time we have a new non-steroid scale, shows that the Opzelura is obviously much better for the eczema and significantly better for the itching than is triamcinolone, which I think is a go-to for most of us, or historically has been a go-to for most of us for flexural atopic dermatitis, even in this younger population. Next slide, please. So this is just the way to look at patient claims, like how many drugs did they have to get filled before they were on Opzelura versus after, and not surprisingly, they needed many fewer prescriptions after Opzelura than before. Next slide, please. Yeah, so this basically just shows that total prescriptions that were failed topical steroid calcineurin inhibitors and PDE4, 1 to 6 months, and then 7 to 12 months after follow-up. And the first line is that lead-in period for the first 6 months. So pretty nice evidence that once the patients get an Opzelura, they really don't need to use steroids. Next slide. Dosing and administration couldn't be easier. Thin layer, twice a day, safe anywhere, FDA approved down to the age of 2. You put it on the lesions directly, but not on normal skin. Again, steroid-free, non-greasy. This one's kind of just really easy to use. Only comes one way, 1 60-gram tube. That's it. Next slide, please. Again, patient support. Obviously when these drugs first get started, sometimes there are challenges, at least in my neck of the woods, which is in Western Pennsylvania, using specialty pharmacies. We've had much better luck getting this drug covered for patients with commercial insurance. I think that 90% is about what we're experiencing. So again, I'm sure you each have people from Incyte that can help you out in your different geographies, but we have found this one easier and easier to get covered over the last couple of months. Again, remember now you can use it down to age 2. Mild to moderate atopic dermatitis, you want to make sure you code atopic dermatitis. As a general rule, patients are going to need to have failed at least a topical steroid, if not that, plus a TCI. Oftentimes when I see new atopic dermatitis patients in my practice, I write a topical steroid and a topical calcineurin inhibitor the first day anyway, whether they're eventually going to need to be on a biologic or something like Opzelura. I think that often just makes it easier. And then remember, for this drug, you want to limit body surface area to no more than 20%. And in our practice, once somebody has more than 20% body surface area, they're usually going to get a biologic. All right, next slide, Roxanne. All right, we did touch on some of this, but I think just go over it because we're required to do that. Patients taking oral JAK inhibitors have been associated with having serious infections, including TB, invasive fungal infections, bacterial, viral, including some herpes infections. We talked about all-cause mortality, which is major cardiac events and strokes. Again, there have been blood clots, and there have been some non-melanoma skin cancers and lymphoma as well. Next slide. We talked about major cardiac events, thrombosis. Again, there have been cytopenias seen in the oral agents, and as a general, when I give oral JAK inhibitors, I do track lab work about every 3 months. We do not give this to patients who are pregnant or nursing. I do not check labs in patients who take topical JAK inhibitors, but I think we're going to talk about that in a few minutes. Next slide. So again, Relief Reimagine, this is the first and only topical JAK inhibitor for atopic dermatitis. Now FDA approved down to age 2 for eczema. It is still FDA approved to age 12 for vitiligo. We have powerful inflammation relief very quickly, as early as 15 minutes for the itch. We have significant improvement at week 8. You can see about 50% of patients get to that clear or almost clear. We have sustained disease control out 52 weeks, and we know that about 70% of patients can get to that clear or almost clear over the 52-week trial, knowing that those patients only really have to use the Opzelura on about half of all those days. So they use it when it's there, not when it's not. So again, I think this is a really good one, and I think it's fantastic now as a pediatric dermatologist that we have a JAK inhibitor down to age 2. So I do give kudos to the company. It is very difficult to do JAK inhibitor trials in children, and so not only is this approved to 12, it's now approved to 2. I think that's great. You can see that there are more than 600,000 patients that have received Opzelura since its release about 4 years ago. And I think now that we have it for kids 2 to 12, that's really going to take off. Next slide, please. All right, so I think that's it. I appreciate everyone's attention tonight. I know that's a lot of material, especially in kids. I think we're going to flip back to Dr. Kaufman, and we can deal with any questions that have come in. Dr. Kaufman?
Thank you, Doug. Thanks. That was great. We do have some questions. You can still put them in the chat box, but we have already quite a few. What were the key inclusion and exclusion criteria in the True AD1 and True AD2 trials?
So the main inclusion criteria for AD1 and 2 is that they had to be over 12. They had to have eczema for at least 2 years. They had to have eczema that was mild to moderate, which is 2 or 3. And they had to have eczema on less than 20% of the body surface area. The main exclusion criteria is they couldn't have been on any biologic within a couple of weeks leading into the trial, or any kind of JAK inhibitor, and they couldn't have an active infection at the time of the trial.
Okay, makes sense. Can Opzelura be used anywhere on the body?
So Opzelura absolutely can be used anywhere on the body. Whenever we have a new topical, and I have somebody who has atopic dermatitis widespread, including face and other areas of the body, I always recommend that they try not on the face first couple days. Try a spot on the arm and leg. If it's well tolerated there, and Opzelura is generally well tolerated, usually they can tolerate it on the face. As a general rule, we don't see a lot of facial eczema after age 2, but this really is safe to use anywhere.
Are any specific lab tests required to monitor patients on Opzelura?
So for topical JAK inhibitors, there are no lab tests that are required or recommended. There's a lot of controversy with oral JAK inhibitors. I do check lab work on oral JAK inhibitors every 3 months. I think if they've been out a couple of years, people have gotten more and more comfortable. I have colleagues who now only check every 6 months on oral JAK inhibitors, but for topical JAKs like Opzelura, I do not check any labs at all. I don't check baseline. I don't check any lab over time. And I think that is probably the standard of care for the topical JAK inhibitors.
I agree. And then lastly, is Opzelura appropriate for patients who have not responded well to other non-steroidal topical therapies?
Yeah, absolutely. I think, as I said a few minutes ago, for most patients to get Opzelura, they need to have failed either a topical steroid or a topical steroid plus a topical calcineurin inhibitor. And I think if you have those patients who failed those, Opzelura is the treatment of choice after that. And I have found that Opzelura can save a number of patients from having to go onto a biologic. For the last couple of years, that has been for me patients over 12 that I've gotten on Opzelura, and that kept them from having to go on a biologic. Now we can do that for patients 2 to 12, which I think is huge. You know, not that the biologics that we have for eczema aren't great for kids over 12 and that the oral JAKs aren't great, but you know, nobody wants their kid on an injection and nobody wants their kid on an oral JAK inhibitor. But you know, the topical one, as I said, does seem to be very safe, and I think it's great now that we have it down to age 2.
Totally agree. Well, that's all the questions we have, Doug. So I want to thank you for that talk and for answering our questions. I want to thank our supporter, Incyte Dermatology, for supporting this session tonight. And just remind you that there will be another IDEF Educational Series webinar next Monday with Ben Lokshin and Evan Siegel. And I think that's it.
That's
I want to wish you all a good evening, and thanks for joining.
Good night, everybody.
Good night.
Thanks, everybody. Sorry about any technical issues.